Dear friends and colleagues, my name is Gralla. I'm the Director of Diagnostic and Interventional Neuroradiology here at the Hospital in Bern, in Switzerland. Thank you much for the kind invitation to the Vietnamese Talk Winter School 2021. It's my great pleasure. I'm going to share my screen with you for my presentation. There we go. The rationale to question IV thrombolytics prior to endovascular treatment in proximal vessel occlusions. And I'm going to elucidate the role of IV thrombolytics as well as the role of the SWIFT Direct study in this context. First of all, thank you very much. What you're doing there in Vietnam is great. You know probably that there is a similar stroke school, the European Stroke Winter School here in Bern. This is the setting of Bern. And very grateful to be part of your school here in Vietnam. So what is the major priority to treat stroke? The major priority is we have to recanalize and as fast as possible. So a triage to the fastest treatment as well as with the highest recanalization rate for the individual patients. How do we facilitate that? You know that there are a couple of randomized controlled trials from 2024, 14-15, which have shown that endovascular treatment is the backbone of large vessel occlusion in the anterior circulation. So the current gold standard we have is IV thrombolytics plus mechanical thrombectomy. And this gold standard is very well established now. You see there's a pooled meta-analysis of the large randomized controlled trials. And the most important figure that you have to remember is compared to IV treatment alone, IV treatment plus mechanical thrombectomy is very, very efficient. So it's one of the most efficient treatments in medicine as far as we know, definitely for endovascular procedures. And the number need to treat is 2.6. So every 2.6 patients, you have a much better outcome compared to IV thrombolytics alone. Very, very effective treatment. But, and that's might surprise you or not, this treatment is still time dependent. So as fast as possible is the key. So what you see there is if you treat the patient within 120 minutes with IV thrombolytics plus mechanical thrombectomy, this is the number of patients having a favorable outcome in green and those with unfavorable outcome in red. And then after 180 minutes, 60 minutes later, another 60 minutes later. So it has to be done very, very fast, very swift treatment. Time dependent, so recanalize fast, very important. The other question is if you apply another treatment modality like endovascular treatment, is it cost effective? And yes, there have been a couple of studies showing that not only recanalization is higher, outcome is better, but this also correlates or converts into economically benefit. So it's highly cost effective as well. So the state of the art currently is for peripheral occlusions, small vessel occlusions, no LVOs. IV thrombolytics is the way to go unless there is a contraindication at the time window. Within the time window of IV thrombolytics, in most of the countries, it's 4.5 hours. It's IV thrombolytics plus endovascular treatment. And beyond that, or with contraindication, it's mechanical thrombectomy alone. So IV thrombolytics plus endovascular treatment. Why is that? If you look at the basic principle of how IV thrombolytics act, it's questionable whether this is the right way to go. What you see here is the pooled analysis of large IV trials. And if I talk about IV, I'm talking about alteplase. There's a different discussion on how to use selectivplase, but this is alteplase studies. And what you basically see is that in low NIH grades, the outcome with using alteplase is very, very good. So highly beneficial if you have low NIH patients. On contrary, in larger NIH, high NIH patients, the effect minimizes. So how does it correlate between high NIH, poor difference between control group and IV thrombolytics group compared to low NIH and a very good effect? Probably the solution is the occlusion pattern or the occlusion site. So what has been elucidated in this study is that you have a large thrombi in the MCA, also a large thrombus itself, so beyond 8 millimeters, the chances of recanalization with IV thrombolytics are very, very low compared to, or very, very high with small thrombi and very, very low with large thrombi. Small thrombi, more peripheral occlusions, highly efficient treatment using IV thrombolytics, large thrombi, rather large vessel occlusion, poor recanalization rate. That means, and that is what we're going to go through different conclusions. This is the first conclusion. IV thrombolytics have high recanalization rates on small thrombi and peripheral occlusions. And on contrary, mechanical thrombectomy are very strong in this. So these are not competitive, but rather complementary treatments. Now, still the question is, why is IV thrombolytics the backbone, apart from the historical part, for large vessel occlusions? Is that necessary? So we're going to have a look at different patient cohorts and try to identify the effectiveness and the factors that influence the effectiveness for IV thrombolytics, and then try to extrapolate whether it's necessary to use it in large vessel occlusions or not. So obviously you have two cohorts. One cohort is the patient that comes to an outside hospital, somewhere far away from Canto, and there is a stroke unit and the patient receives IV thrombolytics, but there are no possibilities of mechanical thrombectomy. So the patient goes to stroke center and referred to mechanical thrombectomy there. In this setting, I can illustrate this on the map of Switzerland. So this is Bern. This is a stroke unit nearby, Neuchâtel. So the patient comes to Neuchâtel and then comes to Bern. So let's look at how efficient IV thrombolytics are when IV thrombolytics are applied here and the patient arrives in our hospital. And we looked at that. So if we have different occlusion patterns and they come from outside and they received IV thrombolytics during the way, and then you see the recanalization rates. If you have peripheral occlusions like M2, good recanalization rates, 30% of the patients were recanalized. Basal artery, 16, and then it drops to 7% of recanalization during the travel in ICA or large vessel occlusion. So LVOs, no great benefit or no huge benefit by using IV thrombolytics. Now, if you look at the very same patients coming directly to a hospital, so they come to a hospital, they receive IV, how often are they recanalized when they come to the angio? You see that the same treatment, IV thrombolytics, is even less effective. So what does that mean? This is from a larger study. If you use no IV, the chance of spontaneous recanalization is very low. If you use IV, then the longer you wait, the more recanalization you get. So basically, conclusion number 3, IV needs time to act. So in a bridging model, drip and ship model, it might be beneficial and helpful, but in a mothership model, going directly to your place, coming directly to control, is questionable whether it makes sense in large vessel occlusion, I've pointed out. So now this is an established pathway, drip and ship, and that might be true for a long time. Now we look at the other ones, the mothership patients. They come directly to Cantor, directly to Bern, and now you can go for IV thrombolytics or mechanical thrombectomy, or you randomize patients and go from entrance, from your emergency, directly to mechanical thrombectomy, skipping IV. And there have been a couple of randomized controlled trials, and this is basically what I'm going to talk about. SKIP, DEVT, Direct MT, Mr. Cleano IV, and the upcoming Swift Direct trial. And they looked at this. They randomized these two arms. And I'm going to directly to the few literature that we have so far. So these are the results of Direct MT. The study has been carried out in China in 41 academic centers. The patient obviously had to be eligible for IVT and mechanical thrombectomy, and was limited to intracranial segments of ICA and MCA. NIHSS greater or equal to, and roughly 650 patients have been enrolled in the two arms. And the idea was to prove non-inferiority. If you prove non-inferiority of using mechanical thrombectomy directly compared to the bridging arm, that's all you need, because then you can skip IV and you're faster, and you don't have to apply a drug, which costs money and so on. So non-inferiority is the way to go. And these are results. So basically, yes, they have proven non-inferiority. So there were no major differences in the modified ranking scale between the endovascular direct arm and the alter class plus endovascular arm, so the bridging arm. However, if you look at the sub cohorts, then you see there's no great difference in death, no great difference in symptomatic hemorrhage and so on, or any kind of complications. But nevertheless, surprisingly, the direct arm compared to the mechanical thrombectomy arm, the bridging arm had a high recanalization rate. So The study shows a bit of mixed picture, but non-inferiority has been shown. There are some downsides of that study. So it's one of the first larger stroke studies from China. Some patients had not even received endovascular treatment, so there have been some crossovers or non-mechanical thrombectomy patients. The door-to-needle time was very low, and patients had to pay for TPA, as in many countries, which might have some delaying effect on the initiation of that particular therapy. Nevertheless, mixed picture, but non-inferiority has been shown, so it seems as if mechanical thrombectomy alone might be equal to the bridging concept. The other big study that has been study that had been published, I'm going to focus on that a little bit, is Mr. Clean No IV. Mr. Clean is a study group which has shown that mechanical thrombectomy in principle has been effective. And again, what they did is that randomizing the two arms, bridging versus direct mechanical thrombectomy. And we're going to jump directly to the results. This is the bridging arm, and this is direct mechanical thrombectomy arm. And what you do see is there might not be great differences, but you do see that, especially in the poor modified ranking score 6, 4, 5, this fraction was even higher in the mechanical thrombectomy arm. So again, a mixed picture, but no clear picture of the benefit of going directly to mechanical thrombectomy. And in fact, if you calculate it, not even for non-inferiority. So this study was, in conclusion, failing to prove superiority of the direct mechanical thrombectomy arm compared to bridging, and even to prove non-inferiority. So from those two studies, you can see we're awaiting effect, but these two studies don't show the same effect. So we don't know still whether mechanical thrombectomy alone is heads up to the bridging arm. There has been, and obviously there have been some downsides of that particular study. I think from my point of view, the most severe one was they included M2 occlusions, and we know that peripheral, small thrombi occlusions might act quite nicely on IV thrombolytics. So that was a downside. There has been a recent meta-analysis. There are a couple of meta-analyses of these randomized controlled trials now. I'm just going to show this to you to show you how mixed gray zone the picture is right now. And in this meta-analysis, they looked at the 4 currently published trials: SKIP, Mr. Clean No IV, Direct MT. I've shown you the images or the results of those two, and EVT. And this is the overall benefit in the primary outcome after 90 days. And what you see here is this is completely heads up the one. And if it goes into this side, it favors bridging thrombolysis. If it goes on that side, it favors direct mechanical thrombectomy. All these graphs will be exactly the same. And what you see is it's basically exactly on spot. Some have shown a benefit, some have shown a downside. So currently, it's not completely clear. If we go in the subgroups, looking at the modified ranking score, some sign of a signal towards mechanical thrombectomy for low NIHSS modified ranking score outcomes. Mortality, we don't see the signal yet. Symptomatic intracerebral hemorrhage, yes. A tendency to higher rates of symptomatic intracranial hemorrhages on the bridging side, not surprisingly. And it seems that any kind of intracranial hemorrhage seems to be higher with a bridging arm, not surprising. Nevertheless, this is the setting that we have, and it's not completely clear. Reperfusion, surprisingly to my point, it seems as if the reperfusion is higher using IV thrombolytics prior to mechanical thrombectomy, and any kind of complication, no clear signal. So in conclusion, basically, even illustrating all these 4 trials, it's not completely clear yet how to use IV thrombolytics in combination. It seems so far as if there might be a benefit of using it. But again, the conclusion, as always, further multi-center randomized controlled trials are awaiting. And probably one that we are counting on, also because Urs and I were the PIs, is SwiftDirect. So SwiftDirect will do the same, or has done the same, randomizing patients in these 2 arms, bridging versus mechanical thrombectomy. And the study has been conducted, I have to say, in these countries. So we're in North America and all over Europe, 43 recruiting sites. And the study has been very, very active. The Inclusion criteria, I just want to point this out because this will hopefully make an impact on the outcome. NIHSS greater equal 5 and below 30, intracranial IC and M1 segment only, so true what we would consider as large vessel occlusions. And then the NIHSS score at time of enrollment or randomization equal or greater 4 on CT and some similar setting for MR. So these are, from our point of view, very pure low LOV patients. The recruitment has finished. That's the good news. It has finished in April already. So we're waiting the study results by beginning of August. So by the beginning of August, we're going to add another data set to that question. From our point of view, a very dedicated data set for large vessel occlusions, and we'll see how this turns out. From our point of view, the setting that we have right now is this is the gold standard currently. So IV thrombolytics for peripheral occlusions, rather for historical point of view or historical reasons, IV thrombolytics plus endovascular therapy for large vessel occlusions within the time window of 4.5 hours, and then endovascular treatment afterwards. And my assumption in the long run will be, I think that IV thrombolytics will disappear in this. But right now, conclusion number 4, it actually has to be, IV thrombolytics might be skipped in large vessel occlusions. However, if you look at this, there's a gap. So now IV thrombolytics, if they wouldn't be used prior to mechanical thrombectomy, then this would offer another possibility. And this is what we're aiming for. So why don't we apply IV or IA thrombolytics after mechanical thrombectomy? So we do mechanical thrombectomy, large vessel occlusion first, and then we have some residual occlusion site, which is probably peripheral. So this is one of these cases. This is a ticket 2B after an M1 occlusion. And what you see there is the vast majority of the territory is recanalized. However, there's a small spot which has not been recanalized, so there's an M4 occlusion still, far beyond the margin of mechanical thrombectomy. So how do we treat that? In this particular case, we applied urokinase, so another lytic drug, intraarterially into the thrombus, and we receive a ticket to C3. So we recanalize with lytics after mechanical thrombectomy of the major bulk of thrombus. That would do both. We would apply mechanical thrombectomy for large vessels where it's very strong, and then apply IV thrombolytics for small vessels where it's very strong. And by not giving IV thrombolytics prior to mechanical thrombectomy, open up this room. So having a recanalization there. And this has been looked at of one of our colleagues, and what you see is there is prior to urokinase in this setting, and then post urokinase, we actually see there is a recanalization effect. So there might be some potential in there. And it seems from what we see right now that it also correlates in some sort of shift in the modified ranking score, and it seems to be safe from all what we see right now. So, and this comes to my final conclusion. This would be probably, if we are able to prove that IV thrombolytics are not necessary prior to mechanical thrombectomy in large vessel occlusions, we get room for improvement after mechanical thrombectomy. Then we can use IV thrombolytics or intraarterial thrombolysis, and that might be the future in the long run. So bottom line, we don't know yet. Hopefully SwiftDirect will give the answer to the role of IV thrombolytics in mechanical thrombectomy for the large vessel occlusions and in the anticirculation. With that, all the best to Vietnam. Thank you very much. It's a pity that the pandemic bans us from coming, but we might do this in another year or two. Thank you very much.